thank you for joining us to learn more about models that shape better care. I'm Dr. Terrence Cescon of Berks Hematology Oncology Associates in Reading, Pennsylvania. I'm here to talk today on behalf of the ACCC to talk about clinical signs of imatinib suboptimal response or failure in patients with chronic myeloid leukemia. First, of course, we need to define our terms. Suboptimal response to imatinib is defined as at 6 months having 35 to 95% Philadelphia chromosome positive cells by bone marrow cytogenetics, at 12 months having 1 to 35%, or at 18 months having 0% but a less than 3 log reduction in BCR-abelson gene transcripts by quantitative PCR. One must consider noncompliance, intolerance, and other medications such as herbal remedies that may interfere with imatinib function. Imatinib failure, on the other hand, is defined as a lack of hematologic response, typically at least a month and up to 3 months into treatment, with white blood cell count greater than 10,000, platelets greater than 450,000, and a left shift with more than both 5% myelo and metamyelocytes added together. Any promyelocytes or blasts would also be concerning. Let's talk briefly about the pre-therapy predictors of imatinib response. There's the Sokal score, of course, where in patients with a spleen less than 6 centimeters in size and 0 to 1% blasts had an average 67-month survival in the pre-interferon era, whereas those with a spleen greater than 6 centimeters and greater than 1% blasts had only a 28-month average survival. But there are other factors, such as social factors, including addiction and other mental illnesses that come into play. Compliance is a big issue, and intolerance must be considered. Imatinib level less than 1,000 nanograms per ml is inadequate. Once therapy begins, early indicators of your patient's response can include plasma imatinib levels, as well as molecular response, and of course, the individual's adherence to therapy. I hope this has helped you better understand how to assess imatinib suboptimal response and imatinib failure in the community setting. Let me leave you with this last nugget. A frank discussion with all your patients, allowing them to have veto authority, and empowering the patient to be an active participant will go a long way to ensure good compliance and care. To learn more about treating CML in the community practice setting, visit the ACCC Resource Center. Thank you again for taking a moment to learn more about the models that shape better care.